Hi, welcome to my YouTube channel, and today I'll be discussing about pneumothorax. We know that pneumothorax carries a very important significance in step 2 CK, and we'll go step by step towards the pathophysiology and management of pneumothorax. So, what is pneumothorax? Basically, pneumothorax is defined as the accumulation of air in the pleural space, which results in partial or complete lung collapse. Now, pneumothorax is of two types. Okay, so pneumothorax is either divided into tension pneumothorax or spontaneous pneumothorax. Tension pneumothorax is the most high yield concept and it is tested very much in step 2 CK. So let's discuss about tension pneumothorax. Okay, so now I will give you a scenario where a patient presents with a stab wound on his chest, after which he developed sudden chest pain and respiratory distress syndrome, and he presented to the ER with respiratory distress, okay, and decreased breath sounds on the affected side and hyperresonance on percussion. Alright, and then he had hypotension and his jugular veins were distended. So they asked what is the best next step in management for such a patient. Now, what tension pneumothorax? So how are we going to treat it? Okay, first of all, we need to understand the pathophysiology. So in tension pneumothorax, when your lung tissue gets injured, it results in the air to leak out of the lungs and to accumulate around the lungs or into the pleural space. The pleural space normally have a negative intrapleural pressure, okay, that keeps the lungs expanded. But when there is any lung injury, it causes the air to leak out of the lung tissue and accumulate around that pleural space. So when that air gets accumulated around the pleural space, when it gets trapped, it results in increasing the intrapleural or intrathoracic pressure. So now it becomes positive from negative. As the intrathoracic pressure starts to increase, it results in collapsing the ipsilateral lung. Now when the lung gets collapsed partially or completely, that leads to decreased breath sounds, okay, then simultaneously it starts compressing the superior vena cava. It compresses the superior vena cava, which brings the blood back to the heart. Okay, so now the heart does not get the blood, and since the heart does not get the blood, so it cannot pump effectively, and it results in decreasing cardiac output and causing hypertension. So the blood backs up as the superior vena cava is being compressed due to increased intrathoracic pressure, right? The blood backs up into the jugular veins, causing jugular venous distension as seen in this patient that I mentioned. Okay, so these all signs leads to obstructive shock. Now as the patient is presenting with this situation, what do we have to do? We have to do needle thoracostomy. Is the most appropriate and emergent step in order to prevent cardiovascular collapse, because some students they opt for endotracheal intubation, and that is wrong. Why would you not go for endotracheal intubation? Because it gives positive pressure ventilation. That means that it will force in more air into the lungs. The lungs already have air trapped around the pleural space. So if you're going to force more air into the lungs, you're going to eventually exacerbate the collapse of the lungs, the tension pneumothorax, and that will lead to cardiovascular collapse. So firstly, you would not go for endotracheal intubation. You will go for needle thoracostomy. You're going to drain the air outside the lungs, and then you're going to go for endotracheal intubation. Although for hemodynamically unstable patients, the criteria is airway breathing circulation, but you're going to go for needle thoracostomy in tension pneumothorax, okay, in someone who is presenting with an obstructive shock. Okay, whereas in spontaneous pneumothorax, okay, if it is less than 2 centimeter or something, like in spontaneous pneumothorax, we know that it just occurs in maybe a thin boy, or maybe in someone who has a ruptured bleb, or maybe in someone who did not have any lung disease. That's primary spontaneous pneumothorax. And secondary is due to a lung disease. Could be due to chronic obstructive pulmonary disease, or could be due to cystic fibrosis or TB. That's spontaneous pneumothorax. But it has the same presentation, like decreased breath sounds, hyperresonance on percussion, and decreased tactile fremitus, and a mediastinal shift away from the side from the affected side. Okay, so it depends on the size, like and if it's minimal in spontaneous pneumothorax, if it's excessive, of course you're gonna go for needle decompression. Okay, but tension pneumothorax concept is tested a lot, so please remember that needle thoracostomy before endotracheal intubation is essential. Okay, and yes, so that was my topic for tension pneumothorax today. So if someone presents with unilateral decreased breath sounds, hypertension, jugular venous distension, okay, and that is pneumothorax. Always remember unilateral decreased breath sounds, hyperresonance on percussion unilaterally, mediastinal shift away from the affected side. Okay, now also if someone is admitted in the hospital, what is the most appropriate way to assess for pneumothorax if they present with these signs acutely? You're going to go for bedside ultrasonography. It can be rapidly performed because it has high sensitivity and specificity for pneumothorax, and it has become the test of choice for evaluation of tension pneumothorax in the acute setting. Okay, so in the trauma bay or ICU, bedside ultrasonography has become the test of choice for evaluation of tension pneumothorax. Okay, and apart from that, in pediatric, you just have to remember that meconium aspiration syndrome is also associated with pneumothorax, because meconium results in plugging of airways that traps distal gas. Okay, so meconium plugging of airways traps distal gas that promotes alveolar overdistension and rupture. So meconium aspiration syndrome can cause pneumothorax in pediatric patients. All right, and we know the treatment, that if spontaneous pneumothorax is small and less than 2, you have to observe and oxygenate. If it's large, then you have to go for needle decompression, that is needle thoracostomy, and then chest tube insertion. And for tension, it's urgent needle decompression and chest tube placement. Okay, so after needle decompression, you can go for endotracheal intubation if the patient is hemodynamically unstable. Okay, have a good day.